Financial disclosures. So here's a 58-year-old gentleman with a known ischemic myopathy, known ventricular tachycardia, has had a defibrillator placed. Risk factors include hypertension, hyperlipidemia, and type 2 diabetes. He's also had a prior stroke, and oh yeah, he's also HIV on heart therapy. And he presents to an outside institution with frank syncope, and a defibrillator goes off. He's then, 911 is activated. He shows up to the emergency room without CPR, actually awake with a troponin of 4. So his interrogation shows VFib, so he had sudden death, he survived. And interestingly, his history is that he had multivessel coronary disease, which was somehow elected to be treated medically up until this point. And he had a right and left heart at this outside hospital. So on arrival, this was his vitals. He was on a whole host of medications, including his antiretrovirals, and he was tachycardic. He had LVH. Now, we don't all look at 12-lead EKGs, but I think they're important to still look at. This is his 12-lead EKG. Notice that he has not lost R waves anywhere. Mm-hmm. He's got SCT wave changes, and he's got atrial abnormality, and he's in sinus rhythm. Luckily, his kidneys are okay. His BNP was 4,000. And I'm going to review his right heart numbers, which were markedly elevated with a wedge of 36, with a PA-SAT of 53, and he had a pulmonary vascular resistance of 8 Wood units, which becomes important here. On his echo, he has a dimension, LVED dimension of 6.8. His LV ejection fraction is below 20. It's globally down, and his RV is also severely reduced. But luckily, he does not have severe MR. He's got moderate MR, which is functional, and no AS or AI, and he did not have an LV clot. I'm going to show you his anatomy. He had a full workup done at the outside referring institution, which revealed a PET viability, which had anterior and inferior viability, but a scar in his apex and lateral wall. And of course, this was a workup what we call surgery workup on the outside before they turned him down, which showed that he didn't have a PE and he didn't have any obstructive disease and his carotids were okay. So here's his angiogram. Variocaudal, his circ is missing. You don't see much in the anterior wall. It's got maybe a puny diagonal or ramus. So LAD is a stump. Circumflex is a stump. There's a tight left main. His right is a tight lesion proximally with a bridging collateral mid with right-to-right collaterals, is dominant right. See the AICD lead. And here's an RAO. And you could clearly see that it's a CTO segment with bridging collaterals and a dominant right with a PDA. It's got no left to right collaterals. It's all right to right. So the CT surgical team at the outside hospital saw him and turned the patient down. Why? 1, because of his pulmonary vascular resistance, and 2, because of his targets, and 3, because of his ventricular function. So the interventional team at the referring hospital saw him and said, sorry, we really don't think we could help you with this. We don't think anything's going to benefit. And he was actually sent to our transplant heart failure team at Columbia for an evaluation for potentially either a transplant or a VAD or something else. And the heart failure transplant team then evaluated him, repeated an echo, repeated a right heart, got hemodynamics. And then because of his pulmonary hypertension and his pulmonary vascular resistance, which was the same high, he was turned down now by our CT surgical program. And then the heart failure team said, I'm not sure what we could do for him except the ongoing medical therapy, which he's already presented with sudden death. What do you think you could do? Is there anything that you could help us with? So what are our options for revascularization? Patient was optimized. What kind of support device do we use? What do we go after? How do we go after it? And the other question, and this will be a debate that we'll talk about after, is do we offer any revascularization to this patient? Is this really a no-hope patient with the information you have and the angiogram you've seen? Shami, do you want to stop here, or do you want me to go over what I did?
No, I think this is a great time to stop and maybe have some conversations. And maybe one of the first ones I think is worth talking about is the whole concept of viability here. Because in point of fact, you had data that clearly demonstrated viability. But if there was lack of viability, would that change the approach? So that may be the first question. That here, this is actually a great angiogram to look at. So you look at this LAD that's occluded, but it does fill. I have to say, as far as targets go, these seem pretty decent targets from a surgical standpoint to me, but I'm not a surgeon.
Agreed.
The LV dysfunction is probably the reason that most often we see these patients getting turned down. And it's interesting, similar to your place, as our heart transplant program has gotten larger and larger, a lot of these patients are being referred to them for VAD transplant evaluation, and somewhere along the way, the revascularization option is not adequately addressed. And I would like to make one comment. This idea of medical therapy somehow being a therapeutic option in the presence of complete occlusions has always kind of bothered me. So even in CTOs, just remember that you will still have ischemia in that territory. It preserves myocardium, but complete occlusions and viable myocardium, then I'm not sure I even necessarily always believe a negative stress test and put those patients onto medical therapy. So anyway, that's an aside. Let's go back to Dmitry. What do you think? Do you need a viability study in this sort of a situation every time before you go to the next step, whether it's surgical or percutaneous revascularization?
I don't think every time you'll need it, but I think in this case, it's extremely helpful. We're dealing here with a very complex case, both from the risk factor standpoint as well as from anatomical standpoint, multiple CTOs. So as you're thinking about your revascularization strategy for very high-risk PCI, I think viability helps you to plan it out, which vessel you're going to go after and how complete of a revascularization do you want to achieve. So I think in this case, a viability is an important test.
Okay. So in general, you would favor getting a viability study. Sheila, do you think, knowing that now you have viability and the surgical turn down is already there, so we have to be thinking about some percutaneous option. Alternatively, if we think about a VAD transplant as our first line of therapy, one of the concerns I always have is you've already gone ahead and done, let's say, a VAD, and you have to go back a second time around. Is that a good way? So let's circle back. Do we want to really send such a patient to bypass surgery? Because in case LV function doesn't improve, they've already had one sternotomy, or are we better off trying to do these percutaneously?
How old was the patient again? I mean, I think it's,
58.
we always talk about this from a
58.
58, so young guy, and it's ischemic disease. It's an ischemic cardiomyopathy, and so revascularization should be attempted. And that discussion in this patient involves a surgeon. So you can't get away with the fact that you might, if you had a surgeon that was willing to take this case, despite the pulmonary pressures, he is going to have a sternotomy. That being said, that's why these discussions are always done with heart failure. So typically they are turned down, but yeah, you are facing the risk of a sternotomy plus a VAD. Okay.
Gautam, the PA pressures are elevated, but the wedge was 36, so a lot of this is probably left-sided and driven. So if you're going to do percutaneous revascularization, what approach are you thinking about?
I think given the fact that a lot of this is likely elevated left ventricular pressures, I think I would definitely consider mechanical circulatory support here, possibly with the Impella device, given the magnitude of the reduction in EF and potentially the need for a long procedure given almost CTO-type morphology of a lot of these lesions. In fact, CTO-type morphology. Potentially there may be a little dot of calcium there that might even require some atherectomy there as well. So given all of that, an Impella CP to maximize mechanical circulatory support that's available would probably be the best option. And maybe reasonable to evaluate whether the legs are a good option for that and the iliacs are a good option for that at this point. And if that's not a good option, if the iliacs are not great, then you might want to think about other options like subclavian access for the Impella, or like we saw, which is also not without issues. and you might start thinking about other options or other forms of mechanical circulatory support.
Would anybody on the panel consider tandem and/or ECMO rather than Impella CP for revascularization?
I would say ECMO going to increase your LV-EDP, so it's already elevated, so probably that's going to be the best option. I think Impella in this case will be a more favorable option, given the elevated EDP and also the having the leg being favorable in terms of size and calcification. Especially if we look at the heart, it's very calcified. I don't think we'll find a very clean iliacs. So we have to keep in mind the alternative access as well, either transcaval or axillary, as Dr. Kumar mentioned. But ECMO will be a more burden on the LV and will be not too much perfusing the coronary in this case.
Manish, what were your thoughts?
So I think these were terrific discussion points. The issue of mechanical support is a non-starter. You need mechanical support in this case. He was optimized, but you need certainly left ventricular mechanical support. The question I have for the panel is, do you need right ventricular mechanical support as well, knowing what you know from the echo with severe RV dysfunction and with pulmonary vascular resistance that's quite elevated? And that's what I actually really grappled over. Sammy, your thoughts on what you would do in a case like this?
Yeah, it's a great question. I don't think I would upfront plan on biventricular support, but I would like to see after left ventricular support what happens. And I would be ready to place right ventricular support before the intervention in case once LV support was placed. Because on occasion, if the RV is really failing, then all that happens with LV support is the situation actually gets worse rather than better. And so that's the approach I would take.
Absolutely, where I was hoping the discussion went. Sammy brought this up, is what type of support devices. And again, there's no role here for a balloon pump or ECMO up front. I think really your options are the Impella CP, whether it be just left or right, and I think the decision for right ventricular support will depend on on how the patient behaves and what the right heart pressures are the day you're going to do this, and also tandem is an option as well if that's something that you do in your lab. So here's the opening hemodynamics after a lot of debate and discussion on the day of the procedure. His heart rate's 100, his PA it's 35 over, actually this is it's a mistake. This wedge was like 30 on the day of the procedure. His PA sat was 53. And so a left-sided Impella was put in. I was ready for right-sided Impella if I needed. And just to go back, I started with the right coronary. It's a femoral case. I had a runoff. His iliacs were fine. Okay, he did not have severe disease, because that would have been an issue, as Gautam, you pointed out. So bifemoral, left with a CP device, the right with this is either a 7 or 8. I think I used an 8 French long sheath. This is a bright tip that we typically use. The 7 French JR4. This was very easily cannulated with a soft wire and a support catheter. And then subsequently I dilated and stented this, and we used imaging and all these. So this was 2 drug-eluting stents. Didn't flinch during the CTO of the right coronary. You see how big this right coronary is. It's an important right. It's got many branches for the posterolateral and the PDA. Here, we take care of the CTO. We don't chase all this down here. This is not something that I want to do today or the day, and this is sufficient as a result for the right coronary. Now, we're not done. He's doing very well. You're monitoring his hemodynamics the entire time. He's stable. He is not intubated. He's comfortable, but it's conscious sedation. So our plan here was to take care of what was viable, and that viability was anterior septal and not lateral. So no matter how much the circ looks enticing, you got to take care of the left main and the LAD system. Bottom line was I parked my first wire in the diag to give myself room. I also wired the circ because I don't want to lose it. I dilated the left main because that was tight. And then once I had support and dilatation of the left main, I went after the LAD. This is an LP with a Pilot 200 that very quickly crossed. You see it on the right panel, sort of a fluorosave. Subsequently, I swap out wires. I don't use hydrophilic wires. To do my procedure, switched out for a wiggle wire, and then you dilate. This is angioplasty. Imaging is critical. You see that first, that diag up top. Okay, I want to keep this provisional. I don't want to make this a full metal jacket here. This is a very diffusely diseased diag. Whole point is to keep it open, but really take care of the left main and LAD and know where to start and stop based on your imaging. So IVUS becomes critical. Make sure that I keep the cert patent, but don't chase it. Here's the imaging, and I saved the imaging runs because they're very long and cumbersome. But 2 everolimus-eluting, drug-eluting stents. Then rewire the diagonal and make sure that you keep that open. Finish the left main with a proximal optimization technique. And like Shami said, this is a nice LAD. I mean, why a surgeon wouldn't want to put a graft on this is unclear, but that's what had happened. So you've got now the left main revascularized with an MLA that's over 8. The entire LAD prox to mid is bigger than 6. You've got the diag that stayed open. Again, here, hemodynamically, he has not flinched. Try not to go after anything else because nothing else is viable. And look at his post-PCI hemodynamics. Wedge is down, PA sat's up, cardiac index is up, his PVR is down. Okay, and again, he is comfortable, he has not desatted, he is not on pressors, and here we always remove the Impella if we don't need it. We always do a completion angiogram here with a crossover technique to make sure this was pre-closed so that we took out the Impella pre-closed and made sure that he had a stable groin. All sheaths were removed. I left his swan in for 24 to 48 hours. The labs remain stable. Now this, just so you know, this is not yesterday or last week. This was 8 months ago. This guy's ejection fraction is 30%. He's class 2, and he's doing everything he wants to do back in the borough of Staten Island where he came from and is quite happy. So I think that these types of cases at times will fall in your lap. I think the discussions were appropriate, knowing that it was viable. The CTO aspect, the technical aspect of it is relatively straightforward. It's a matter of making the decisions and making the effort to say yes and go ahead and completing the procedure. Thank you.
So that's how a master operator does it, and I want to really commend 2 other points that you should take away. First, doing the right coronary so that actually makes your left-sided intervention a little safer. Second, when you have bifurcation disease and you're dealing with a very complex anatomy, the goal is not to start chasing all these side branches and end up with multiple bifurcation stents. So the provisional approach is really the way to go. And at some point down the road, if you have to come back, you can focus on the distal right, you can focus on some of these diagonals, and over time, figure out if more intervention needs to be done. Great case.